All right, so my name is Mailae Halstead. I am residing from Podunk and Nipponk land, also known as Manchester, Connecticut. I specialize in OCD, PTSD, and psychedelic-assisted therapy, and I'm part of the Multidisciplinary Association for Psychedelic Services, also known as MAPS, as part of their expanded access team in Connecticut as a treatment advisor to use MDMA to treat post-traumatic stress disorder, or PTSD. And I'm also a teaching assistant for the Integrative Psychiatry Institute's Psychedelic-Assisted Psychiatry Training Program. All right, great. So just a brief overview of some of the things I'm going to be touching on today, kind of what psychedelic-assisted therapy looks like in a clinical setting, what is ketamine and ketamine-assisted psychotherapy, and how the clinic I work at uses ketamine to treat racialized trauma. I'm also going to be presenting on a case study with the permission of one of my prior clients, and a discussion on the barriers and issues around accessibility. And so just to kind of start off, what is psychedelic-assisted therapy in a medicalized setting, and what am I referencing to when I mention that? And so it just means a psychedelic substance that's paired with traditional therapeutic interventions, but as well as other interventions such as kind of like shamanic backgrounds and ceremonies that we put in conjunction with this. And so over the last decade, there's been significant interest in psychedelic-assisted psychotherapy for the treatment of a variety of mental health conditions, such as anxiety, depression, substance abuse, OCD, and post-traumatic stress disorder. And in fact, a growing body of research is indicating that psychedelics and substances that induce non-ordinary states of consciousness can provide significant reduction in symptoms, so much so that the FDA is granting some of these substances what's considered breakthrough therapy, or basically meaning that the substances, compared to what is currently available for treatment, they go above and beyond that. And so ketamine has been granted this. And while I'm talking about the clinical kind of aspect of this, I do want to mention that most of the existing literature on psychedelic therapy is from a Eurocentric medicalized perspective, oftentimes omitting indigenous use or discussing its origins in a very detached historical manner. And so it must be noted, while these Western ideals of quantifiable science, deeming psychedelic therapy as legitimate, several indigenous cultures across the globe have practiced using several plant medicines for hundreds of years. And these medicines are not new, and though ketamine is plant-based, the way I personally use psychedelics to treat my clients is nonetheless pulled from indigenous practices and healers, and must be noted here. And so what is ketamine? Technically, it's not really a psychedelic. It's considered a dissociative anesthetic, but it has a lot of psychedelic qualities there. And so it's safer to administer than other types of anesthetics for pain relief agents. It doesn't depress your breathing or lower your blood pressure. However, with that being said, it has this really great secondary benefit of reducing depressive symptoms amongst other mental health symptoms that pop up for folks. And some research suggests that ketamine can also be used for effective treatment of PTSD. PTSD is a chronic and debilitating condition arising after the exposure to a severe traumatic event characterized by re-experiencing, avoidance, and hypoarousal symptoms. And these may develop immediately after exposure to the trauma or years after. And in the general population, the prevalence of PTSD is about 7%, and higher rates in trauma-exposed populations such as BIPOC communities. And so, however, when treated with this class of drugs such as SSRIs, which is normally your first line of treatment here, the response rates rarely exceed 60%, which is not very good. And most patients who do have that, only 20 to 30% receive full remission from their PTSD symptoms. And so as you can see, that's not really reasonable here. And most of the clients that come to us have what's considered treatment-resistant medical conditions or mental health conditions, meaning that they have failed to medications such as SSRIs, or basically your basic antidepressants, have tried therapy amongst other interventions with little or no success. And it's important to emphasize that ketamine has shown, and why it's so important here, to increase structural plasticity in the brain. You just kind of heard the previous presenter mention that. And so basically that means our brains are really efficient at learning after having been administered ketamine. And so due to the potential benefits of ketamine-assisted therapy brought about by a state of this increased plasticity, there's this really fantastic period of time after administration. You also see this with psilocybin as well, and more studies are being done on other psychedelics, where there's this critical period of enhanced learning. And myself, I come in with different therapy modalities, and I hope that this client is able to receive this in a way that maybe they couldn't before prior to the psychedelic experience. And so racial trauma, this is pretty self-explanatory, but just to kind of give you the overview of what I'm referring to is just a traumatic response to race-related experiences that are collectively characterized by racism, including acts of prejudice, discrimination, and violence against subordinate racial groups, and attitudes of superiority held by the opposing group here, in many cases white people. And racial trauma can be caused by overt or covert actions carried by individuals or entire societies. And so PTSD is a distinct mental health diagnosis that kind of requires exposure to traumatic incidences as part of the diagnostic criteria. And so whenever we're kind of working within a clinical settings, ethno-racial differences can arise when diagnosing PTSD due to the prevalence of trauma exposure for different qualifying events. And so these different types of exposures to racial instances such as immigration, witnessing war, and witnessing domestic violence, or in some cases to assaults, body searches, community violence that people of color and BIPOC communities experience disproportionately in comparison to the white population. And so while the aforementioned acts of racism are much more covert, there's also subtle forms of racism, such as microaggressions, that include a variety of verbal and nonverbal communications, intentional or unintentional, that are also compounding upon a person's psyche, and that are also contributing to these traumatic responses that some people have. And it's demonstrated very many negative implications that it has on people's mental health, as well as these covert acts too. And so due to the distinct ways in which BIPOC communities may be exposed to traumatic events, they don't always neatly fit under criterion A qualifiers to diagnose PTSD, and this is a serious problem. People within the white medical community might have arguments about the legitimacy of discrimination and oppressive acts viewed as not worthy of this PTSD diagnosis, and then people getting care they need, because some people may have argued that usage of racial slurs or not viewed as violent unless it's not met with an explicit threat, which is kind of an issue, as you can see here. And so this is an ongoing systemic hurdle when it comes to discussing these issues. So I want to share a little bit about a case study. And so I think that storytelling is a really powerful tool that sometimes can demonstrate the ways in which, in a medicalized setting, when done under the right conditions, ketamine can effectively be used to treat racial trauma, and in the right circumstances can be used to effectively treat PTSD. And so not everyone has access to this type of clinical care with psychedelics, and to be completely honest, I think in many cases when it comes to treating in a medicalized setting, MDMA is probably still the most appropriate medication. However, this is not to say that under the right conditions, ketamine can be appropriate for trauma too. And I hope that this treatment style and protocol can provide a glimpse into what is possible within the clinical settings to use psychedelics whenever it's used responsibly. And so I'm going to start by saying that this case here with Robin, who's a 58-year-old African-American woman, this took place in the summer of 2019 when we began treating her. And so she was self-referred to our clinic after going on disability after experiences of race-based discrimination in the workplace. She had complex PTSD due to years of traditional talk therapy attempting to resolve her past traumas without much help. And so at the time she reached out to the clinic, she was actually in a high-profile PTSD program and unfortunately experienced microaggressions by white providers there. And she was in search of relief from her symptoms and wanted to process and treat the race-based trauma so that she can go back to work and live her life again. And the client did come to the clinic from out of state in order to receive this care, and she came from a predominantly white area. And so at the time, Robin had an extensive symptom presentation. As you can kind of see here, she experienced feelings of hopelessness around her mental health challenges and was ready to explore the option of ketamine-assisted psychotherapy after trying several other treatments that were supposed to work without much effects. And so some of the, when beginning treatment, she was very isolative and struggled to make trips to the grocery store due to fearing that she might experience further acts of discrimination. So for instance, Robin reported being worried about microaggressions that she would likely face in public interactions and how it might further exacerbate her PTSD symptoms. And although she was able to carry out various activities of daily living, she struggled with anticipatory anxiety that would last for hours at a time. She also felt that she didn't have any close platonic friendships. She was in a predominantly white area, I think I mentioned that before, and so it was difficult for her to trust anyone because she assumed that they would either not believe her experiences or understand the extent of what she experienced. And she explained that it felt safer to keep to herself rather than put forth effort into fostering any other relationships. And so She also had a very challenging upbringing filled with extreme abuse and neglect, and she would story experiences where she would sometimes go without food, experience sexual and physical abuse from multiple family members, and be the target of severe racial discrimination while attending public school. She also disclosed that she was often called various racial epithets, as well as being spit on and assaulted, and just as a trigger warning for physical violence. She had told her parents as well as teacher this for several years, but no one intervened until she was in the 3rd grade, where she was being bullied and was knocked out by another child, and her front teeth were knocked out. And so it wasn't much later in life that Robin pursued treatment for PTSD and was officially diagnosed in 2003. And she reports a variety of gold standard treatment modalities that simply just did not work for her, such as antidepressants, many different types of therapy, and only found that a mixture of what's referred to as DBT therapy or dialectical behavior therapy with anti-anxiety medications to be useful. And so she also underwent what's considered an intensive outpatient procedure in 2017, where she felt it provided some relief from her experiences, but despite receiving successful treatment for various adverse childhood events, her PTSD symptoms returned when she was re-traumatized at work, where she was repeatedly discriminated against once more. In fact, she successfully won a lawsuit against the discrimination case, but nonetheless of winning a lawsuit, she still had PTSD symptoms. And so, since 2017, she continued ongoing treatment with a local therapist. And so again, kind of conceptualizing how we treat clients of color whenever coming to our clinic. And so her symptoms were conceptualized through a culturally informed model of how cumulative traumatic events acquired over time can lead to PTSD. And since the social determinants of health have direct impacts on treatment of trauma, we also considered her unique social background, such as her age, gender, geography, and education, to inform the treatment plan. And both sexual abuse and racial trauma is presumed to create assumptions about her views about herself and the world. And so these experiences led to feelings of worthlessness, inadequacy, and hopelessness, which further exacerbated from the subsequent work-related discrimination she experienced. Her adverse childhood experiences, coupled with the sexual and racial traumas, led her to developing limited belief system, which complicated every aspect of her life. And due to living in a rural, predominantly white area, she recalls experiencing acts of discrimination in the majority of her social outings, like I mentioned the grocery store earlier. And so the treatment approach that we had for this, we took kind of an eclectic approach to treatment, guided by several empirically treated support orientations. And so we treated her using what we call functional analytic psychotherapy, as well as mindfulness-based cognitive therapy, coupled with the ketamine sessions. And to address the symptoms that she reported, the FAP therapy there provided an excellent model to kind of develop emotional intimacy and really build rapport with her and build a therapeutic alliance that we could work from. And because she endured countless instances of discrimination, it was important that the therapeutic modalities not minimize or misinterpret her experiences, but validated and provided compassion. And so for instance, when she shared her experiences, we didn't respond with a mere thank you for sharing. We validated the injustices, helped her name the pain, and bore witness to the stories, and in turn helped Robin deepen her understanding of the experience, instead of just continuing to kind of ruminate over what happened to her. Another thing that we found an important component is that it was a diverse treatment team that we worked with. And so my mentor here, one of my many mentors, Sarah Reed, is a Black woman who's also a licensed marriage, family, and therapist. My background is also multicultural and Creole, and home was Native American. I'm also a therapist. The prescribing clinician, it was a white man, Dr. Krause. He's fantastic. He's a board-certified nurse practitioner who does prescribe our ketamine. And then my supervisor, Monica Williams, who is also a Black woman. We also had the commonality of all being trained in working with diverse populations, as well as having undergone psychedelic-assisted therapy training with MAPS. And so the course of our kind of treatment here. And so treatment took place over a 13-day span where she met with myself and Sarah, and our prescribing clinician. She completed a series of both drug as well as non-drug treatment sessions throughout her IOP, including preparation, dosing, and integration sessions over the 13-day period. We administered 150 milligrams of ketamine sublingually on 4 days of the treatment. And while there are many administration routes for ketamine, our clinic chooses to use lozenges. And I'm learning that our medication sessions are actually a lot longer than the way a lot of other people do it, compared to intramuscular IM or intravenous or IV. And so those are typically 45 to 90 minutes, and while our sessions are closer to 2 to 4 hours long. And the lozenges kind of allow for a more gentle descent to the altered state of consciousness, and while there's a slower come up, we find this to be really useful for processing trauma. And in terms of frequency of the treatment, Robin met with myself or Sarah jointly or individually for 90-minute therapy sessions during integration and preparatory days. And the spacing of these sessions were based largely upon MAPS's protocol with MDMA. So some of the pre-treatment that we did, so of course we kind of go over a basic assessment in order to understand her symptom presentation. And during the assessment, she reported high suicidality, thinking about suicide roughly 4 times a week, but reported no current plan or intent. And she reportedly had a safety plan in place with her local therapist, who was also aware of her suicidal ideation. And she had a complex history of trauma, as we mentioned before, so we understood that building rapport was incredibly important for her. And after completing the initial eligibility with us, she went into ketamine treatment to be evaluated by her prescriber to ensure that she was physically going to be safe for this. And so what some of our preparatory sessions looked like for this person, we began treatment by going through an informed consent process in detail, highlighting the current research that was available, as well as the subjective effects to be expected and expectations for dosing sessions, and the ongoing process of consent and treatment. And so the deliberate and detailed informed consent process was critical in building trust with her, and as well as any of our other BIPOC clients, due to just the historical harms that are inflicted on those communities and the medical practice in psychedelic-assisted research as well. And so our informed consent is also ongoing, and we make it extremely clear that the client can revoke consent without any sort of penalty. And overall, Robin described the desire to learn new skills to deal with discrimination she experienced in the workplace. She expressed wanting to work towards developing meaningful relationships with other BIPOC folks, given that she was living in that predominantly white suburb. And although she expressed some anxiety about the dosing session, she was overall optimistic and motivated to begin treatment. Because she experienced multiple traumas throughout her life, starting in her early childhood, it was important to understand how these compounded incidences impacted her beliefs about herself and the world and her current relationships. One of the ways that we gathered information was through a cultural genogram. And a genogram is like a family tree, but it also demonstrates relational patterns, including medical history, mental health history, amongst other things. And so through this cultural genogram, we were able to identify various internalized messages that the client was operating from, such as your abuse doesn't matter, Black people are worthless, and I am stupid. And these ideas became internalized beliefs for her that it organized the way in which she responded to the world around her. And so we were also able to explore some of the intergenerational trauma passed through her lineage and her family. Some of these themes of distorted views about her ethnic identity, dysfunctional interpersonal relationships, feelings of anger, fear, and shame. And the examples of the question we used to gather this info included, what did your family teach you about Blackness? Was lighter skin privileged in your family? What messages did you receive about your skin tone and hair texture? Did your siblings discuss experiences growing up in segregated schools versus your experience in integrated schools? And after obtaining relevant clinical information and developing goals with her to achieve treatment, during treatment, we spent time providing psychoeducation on various grounding and regulation techniques to help guide her through experience, such as diaphragmatic breathing, some somatic interventions, and mantras such as I am safe, in order to support her during potentially difficult material. And the techniques were provided to support her to both stay with and deepen her experience and help her push through the difficult emotional processes in a way that didn't continue to do cycles like she had before, where she might push a situation away and not feel the full emotions because it was just simply too painful. And so she was also instructed to complete kind of a thought log to start to challenge some of those core beliefs in a really structured way, which she found tremendously helpful. And during the preparatory sessions, we also developed an intention setting, or what is basically a detailed goal for the client during their experience. And this can provide a sense of focus whenever the material might be difficult for them. And so during the first dosing session, this always takes place at our prescriber's office, just to, again, make sure that the client doesn't have any negative reactions and that she's completely safe. The success of the initial session then deems for the remaining sessions to be done at our office, which is located about an hour away, and that our prescriber is available by phone should non-emergent complications occur. And in addition to the written consent provided to her, we also obtain verbal consent for a dosing session too. And so our setting includes kind of a warm office environment, lots of live plants, candles, a mat with pillows, and we really structure this based upon what the client's individual needs are. If they want this to be more ceremonial and ritual-based, we absolutely bring that into our sessions. If they want it to be more medicalized in order to bring them comfort, we're willing to take that chance too, whatever the client might need. And so when we do this, first starting at Dr. Krause's office, we do check the client's vitals to make sure that they have made all the lifestyle modifications they might need, such as not taking certain medications, to ensure that they are completely safe during these sessions. And during the initial onset of her first dosing session, she reported feeling the most relaxed she had ever felt in her entire life. And coupled with the relaxation, however, she also mentioned that she wanted to just start processing trauma as soon as possible. But we understood with the kind of a complex trauma history, as well as the context of her being a Black woman and not having the space to relax oftentimes, that it was maybe reflexive for her to want to get to work, and that to maybe stay with that relaxation feeling was really imperative to her own treatment goals. And so the context of her journeys included things like relationships with her family of origin, childhood sexual abuse, and many instances of racial trauma. She encountered various somatic pain throughout the process, in which she was able to successfully utilize breathing techniques to move through this moment. She also described various disappointments that she had with herself and others close to her. But it was a new experience for her to be witnessed and validated by therapists as she reprocessed these childhood wounds. And at the ending of all of our sessions, we always do kind of a risk assessment, making sure that the client is completely safe and free of suicidal ideation should that occur. And so this is this is kind of like a setting that we do. It's very much modeled after MAPS's as well. This image is from MAPS's MDMA-assisted psychotherapy, and we create a very similar dynamic in our office as well. And so throughout the medication sessions, as treatment continued, Robin continued to integrate and develop healing practices around her somatic manifestations of trauma. For instance, the ongoing anxiety and distress that she experienced and the pain in her back and her pelvic area, she explored through various self-regulation techniques such as humming or tapping, and to help her ground into the present moment. She began building awareness around the trauma responses so that she could explore what it was like for her to be intentional and consider her choices outside of a fear response when encountering intrusive traumatic memories. An important bit that I would like to include here is that, as you can see, at some point she had made really painful contact with some moments that she had suicidal ideation while under the medicine. And so people do sometimes indeed experience suicidal ideation under these instances that don't necessarily result from what's referred to as ego dissolution. If you're not familiar with that term, that basically means it's a phenomenon where your subjective sense of self kind of feels like it's dissolving or lost, and it can be very uncomfortable and anxiety-provoking, though really helpful. But however, in this instance, this client recalled a very traumatic memory, and it was very painful for her. And so it wasn't related necessarily to ego dissolution. And so, but however, we treat the suicidal ideation that came up with a very specific level of care, because we don't want to incorrectly pathologize a client's suicidal ideation under the effects of psychedelic medicine, but we also want to create appropriate space for the emotions that are present. And this is why there's careful consideration should be made with treating PTSD with ketamine, because while suicidal ideation can result as a side effect of the ketamine, it doesn't have the heart-opening effects that MDMA typically does. And so recounting the traumas can still be quite painful, even though the pain might be dulled some. And so in the final dosing session, she was able to actually begin applying for new jobs at a completely different region of the country. Her symptoms had decreased significantly, and she was worried, though, however, about facing additional traumas from the exhaustion she had felt as a Black woman existing in oppressive spaces. And so while, of course, we talk oftentimes about the medication sessions, we also want to include the importance and the power behind integration sessions, as it's just important, if not more. And we want to put these insights that we gain from the medication into practice. And these sessions were spent further consolidating the gains from those sessions, including processing the trauma, developing coping skills, and spending a lot of time doing mindfulness as well. And so when asked what she was able to take from this, Robin reported that she was more aware of her emotional processes and felt that she was able to be proactive rather than reactive during moments of stress. She explains that she hoped to translate these skills into the workplace into the near future and be able to have a healthy lifestyle that didn't include just her working. And so this is basically a general kind of overview, and I want to speak a little bit about, as you could see, the increase in her depressive symptoms again in the 6-month period. And so after the IOP, she did experience a significant decrease in her symptoms after that 2-week span. She was actually able to begin sleeping more throughout the night, from 8 to 10 hours after only getting 4 most nights. She also described fewer ruminative thoughts and feeling more in control of her trauma. And so to kind of look at that 6-month part there, so basically at 6 months, this is actually when COVID had occurred. And this client had, in this process, moved across the entire United States to begin this new job and live in this new life. However, with that being said, it didn't stop from the fact that she was still developing new friends, new support systems, and she also encountered a lot more trauma at her new place of employment, which, as you can imagine, was incredibly difficult as one is trying to heal. We also had various follow-ups with her at 2 and 3 months. And so Robin had responded explaining that she was able to implement a lot of these interventions in a way that was incredibly powerful for her, that reduced her negative self-talk. She mentioned really powerful, encouraging statements like, "I set the standard for my life. I am flexible and can adapt to change, and I honor my past, but does not dictate my narrative." So kind of following with that 6-month follow-up, she had another medication session with a much lower dose, because this was kind of virtual at this point in time. And this did reduce her symptoms once again back to a much more manageable range. And she was able to continue ongoing therapy with us in order to manage her symptoms. She reported feeling her mood had lifted and was able to feel like she was kind of back to square one again after processing what had occurred to her in her new workplace. And so, with that being said, though Robin had a lot of success with this, I think we need to still address access to barriers of care here. So I could literally do a separate talk on just talking about access and barriers to care when it comes to psychedelics. Robin's case, the trauma of racism combined with the barriers included access in her local area, financial constraints, stress of a legal case, and lack of adequate support system. The events leading up to the discrimination case that, yes, she did successfully win, didn't stop the trauma that had already occurred to her. And so after the case where the symptoms had increased greatly and she couldn't work any longer anyway, and while we had decreased them again, she still once more experienced discrimination. And so while psychedelics provide this beautiful tool, it doesn't take away from the systemic issues that are ongoing when it comes to receiving these types of medicine. This is still a very structural issue we have here. And so in addition to the financial constraints of not being temporarily disabled and having the funds to necessitate this type of treatment, she had to cross state lines in order to see us and obtain quality treatment in this way. And so when it comes to this, she also had to arrange lodging and transportation. As you could see really quickly as I'm discussing this is expensive work when it comes to being done this way. This is not available to everyone. And so when I do this work, I'm oftentimes reminded of Resmaa Menakem's quote that Black bodies don't deal with PTSD, they deal with persistent and constant stress. And so a lot of you might be already familiar with the disparity that also happens when it comes to psychedelic research here, where that more than 80% of psychedelic studies from 1993 to 2017 were done on white participants, but we're still trying to use the efficacy of this to say that it also works with people of color when you guys go back into a world that oftentimes is not welcoming to you. And so the majority of the clinical studies here, while the increased rates of PTSD have been found much higher in groups in BIPOC communities, these things need to be considered when we're doing this in a medicalized setting. And so consider also that while Black youths use drugs at lower rates than white non-Hispanic youths, that Black Americans are also less likely to suffer from substance abuse disorders, but are 3.5 times more likely to be arrested on drug-related offenses, and are 7 times more likely to be incarcerated for using drugs compared to white Americans. And so when considering how psychedelics are becoming decriminalized and legalized within many medical settings, this does not create a safe space for many BIPOC folks. And so clinicians also are a big barrier here, I'll be honest with you. And so if clinicians are unaware of their biases and prejudices when doing this type of work, there are very well documented patterns of mental health underutilization or premature termination due to not having a safe space even within the therapy office. There are higher levels of multicultural competence and stronger therapeutic alliance have been found to reduce these premature termination patterns, however. But I personally have BIPOC colleagues, myself as well, who will not have white sitters during their journeys due to the increased potential for injury. And so I do include this comment not to necessarily stoke fear, but to bring forth an awareness and further emphasize that there is more work that needs to be done here. And so while the mental health care system, as psychedelics becomes more increasingly available to the general public, you're requesting that a group of people who have been seriously disenfranchised by various systems trust you as a clinician to administer a substance that in a different setting could lead to their incarceration or other forms of violence. And so this work is beautiful, but it clearly comes with a different set of risks for certain groups. And so to kind of wrap up here, because I know I'm short on time, this can be an effective approach when certain takeaways and different care is considered. And so I think in many ways that despite the PTSD symptoms that the client I mentioned and shared her story with was able to receive, she was able to regain functioning in all domains of her life, it still doesn't take away from the systemic barriers that came up. And so psychedelic-assisted therapy, if cultural and racialized materials arise during these sessions and therapists are not prepared, it is imperative that therapists be aware with openness, curiosity, and in order to maintain cultural humility when doing this work in a medical setting. And in instances such as Robin, it's also important to continuously assess for the support systems that she can have, finding that back in community. This work would have looked a lot different if there was a bigger psychedelic community around her that she was able to access or knew how to access. And so I consider and continue to remind myself of this as a clinician doing this type of work, how important community is. And so while this case study suggests that existing evidence-based treatment delivered in necessary adaptations can produce successful outcomes, I hope that this is also a takeaway that you all receive from this, is that there's still way more work to do. This work is really sexy, it looks really cool, but it's been known by Indigenous people for a while, and we need more people of color to have access to it. And so just to kind of wrap up, at the end, I would like to end my presentation with an acknowledgement of Indigenous healers, the traiteurs in my family that were before me, and the healers who inform my practice and all of the current clinical uses of psychedelic medicine, by ending with this quote by Maria Sabina. Cure yourself with the light of the sun and the rays of the moon, with the sound of the river and the waterfall, with the swaying of the sea and the fluttering of birds. Heal yourself with mint and neem and eucalyptus. Sweeten yourself with lavender, rosemary, and chamomile. Hug yourself with cocoa bean and a touch of cinnamon. Put love in tea instead of sugar, and take it looking at the stars. Heal yourself with kisses the wind gives you and the hugs of the rain. Get strong with bare feet on the ground and with everything that is born from it. Get smarter every day by listening to your intuition, looking at the world with the eye of your forehead. Jump, dance, sing, so that you will live happier. Heal yourself with beautiful love, and always remember, you are the medicine.